Hello, welcome everybody to our first English version of Artifact-Free, which due to popular demand, we will now also provide in English occasionally. And over the next 10 minutes, we'll cover 3 of the most interesting recent studies in radiology. Today, we are looking at how imaging is getting more precise, giving us richer information and doing it all in a gentler, more patient-friendly way. So the bottom line is see more, know more, and scan smarter. My name is Florian Schwarz. I'm head of radiology at the Donau-Isar-Klinikum in Deggendorf, Landau, and you're listening to Artifact Free. And today's heading is Smarter Scans and Kinder Care. So the central question is, how can imaging help us see more and understand more deeply and still go easy on patients? Let's take this step by step, right? So first point is detection. So how can we find disease as reliably as possible? And our goal here is not to miss anything that could have any important impact on patient care and treatment, right? And one of the most important questions that we have to answer is, how far has a cancer really spread, especially when the patient comes to us for the first time? So we have to make a very clear call on that. And the answer to that determines the entire treatment strategy. And it can range really from an aggressive curative treatment to palliative care. And this is where the first study that we discuss aims at, and that was FDG-PET CT in oligometastatic disease in locally advanced breast cancer. This was a post-hoc analysis of a study that compared the typical workup in locally advanced breast cancer that typically consists of CT of the thorax and abdomen combined with a bone scan, that compares this with FDG-PET CT. And so there was the hypothesis that the conventional staging consisting of CT and bone scan might miss small deposits of cancer, to which the novel approach with FDG-PET CT might be more sensitive. As you know, FDG-PET CT combines the anatomical detail of CT with the metabolic map to light up cancer cells. One of the important terms in this context is oligometastatic disease, or simply OMD. And this has been quite well established over the last years for various cancers. And it typically includes cancers that have 5 or fewer distant metastases. And this is important because at this stage, curative treatment strategies are often still possible. And so what you see in this big study comparing those 2 initial staging approaches is that PET-CT identified this oligometastatic disease in 11% of patients versus only in 4% of patients who underwent the conventional imaging approach. So when you look at that for the first time, you might think, well, patients in the PET-CT arm were doing worse than patients in the conventional arm, right? But of course, those arms were pretty large. So they included more than 180 patients in either arm. And so when you see that in the PET-CT arm, you found 19 patients who had oligometastatic disease versus 8 in the conventional arm, the thing that is suggested here is that conventional staging simply is not sensitive enough. So the message here is that apparently PET-CT seems to be more sensitive to oligometastatic disease and seems to pick up oligometastatic disease more reliably than conventional staging does. So once you diagnose oligometastatic disease in locally advanced breast cancer, you immediately jump to stage 4, and this of course changes treatment. And so the authors here conclude that conventional staging, CT and bone scan, underappreciates the true rate of oligometastatic disease at initial diagnosis, and whereas PET-CT finds true oligometastatic disease and enabling better trial design for metastasis-directed therapy and avoiding futile aggressive treatments. Of course, this has to be seen in context, and it typically takes a long time until guidelines who address staging scans are changed. This, of course, also has to be reproduced, and also there has to be more data about that. But the results of this study would suggest that FDG-PET CT is more sensitive and finds oligometastatic disease earlier than conventional staging approaches. So the second topic would be characterization. Know more, not just seeing more, but understanding more about the things that we see, right? And this would be, for example, what the biological features of the tumor that we're looking at are. So the idea here is not only to find the tumor, but also to see, for example, what the biological weak points of the tumor are. And it would be great if we could already assess that at radiologic imaging. And this is especially intriguing for hepatocellular carcinoma, HCC. And this is what the second recent publication in radiology addressed. So this looked at the non-invasive tumor profiling, looking at MRI radiomics for hepatocellular carcinoma. And the authors tried to find out if information about various mutations could be derived from MRI radiomics. What is known as that HCC is highly heterogeneous. And so biopsies are difficult because they suffer from a sampling bias. They capture only a small section of the tumor, and important information can be lost depending on where you sample the tumor. You might get wrong information regarding the guidance for targeted immunotherapy. And so radio generally is the technique that analyzes MRI datasets in a very sophisticated way and derives from 3D voxels in datasets various highly advanced derivative parameters which go far beyond what can be typically appreciated by human observers. And so this has typically been called a digital biopsy because you, from any 3D region of interest, you can derive very many different features that can be used to characterize this 3D region. So this is an abstract visualization of that MRI radiomics. So the scan is performed, then you delineate the tumor on the scans and feature extraction is performed, and you end up with various parameters. And now what the authors here did was to use those radiomics features in combination with a machine learning model to predict various histologic parameters that were derived from conventional sampling. So those mostly refer to molecular statuses or molecular markers predicting immune response. And as you can see here, the predictive value was pretty high. The predictive value is expressed in the area under the curve, which typically has a range between 0.5 and 1.0. The higher your value is, the better your predictive value is. And so you see here that especially for PDL1, model performance was pretty good with 0.85, but it was also good from P53 mutations and one other parameter that is quite important in hepatocellular carcinoma. And so the authors conclude here in this study, which included almost 100 patients, that non-invasive knowledge of those markers could optimize patient selection for immunotherapy. And this could be derived quite confidently from MRI radiomics parameters. So in the future, you could imagine that we can, after performing an MRI and detecting hepatocellular carcinoma, potentially already make a very good guess about whether it would be amenable to immunotherapy or not. And it would be interesting to see if this could even be better than conventional biopsies, because the problem of the sampling bias would not exist. And then finally, our third topic, scanning more gently, especially in children, because MRI can be a real challenge for the little ones. And I think most of you have small kids or who were working with small kids in radiology know that from a child's perspective, MRI is a pretty frightening experience because they see a long, loud, and narrow tunnel. And that's why often the only option to get good images or diagnostic images is sedation or even general anesthesia. And both, of course, carry risks, especially in young patients who have chronic disease. And so what the authors here did, and this was published last week in Pediatric Radiology, was they explored the utility of audiovisual distraction technologies, which is a very cool way of expressing that patients were just watching movies more or less, or listening to music. And this, of course, makes MRI experience calmer and less frightening. And so what the authors found was that prior to the introduction of this audiovisual distraction program, 92% of pediatric patients underwent sedation for MRI scanning. And once they started that program, there was an absolute reduction of about 1/3 in sedation rates in pediatric patients. And they found that without any compromises on image quality or efficiency. So the program shows that we can maintain diagnostic quality while significantly reducing the need for sedation. So that would be a win for children, for parents, and also the entire team, right? And so I want to summarize those 3 scientific manuscripts. The key takeaways here, as I think, are that FDG-PET CT picks up oligometastatic disease in locally advanced breast cancer more often than traditional methods. MRI Radiomics is opening up a whole new dimension in hepatocellular carcinoma, the virtual biopsy, and audiovisual distraction techniques shows something important, that radiology can be not only more diagnostically precise, but also more human-centered. What does this mean for us as radiologists? We are no longer just image providers. We're actively shaping the treatment pathway, and we are delivering value beyond just producing a written report. And so the technology here is not just getting more precise, but it's also becoming more integrated. It's becoming more patient-focused, and it's placing radiology more firmly at the center of clinical decision-making. And those of you who participate in tumor boards already know the central role of radiology, that is something that is really at the heart of our wonderful specialty. And so that's it for today. A quick look into the future of radiology, more precise, smarter, and gentler. I'm Florian Schwarz, and this was Artifact Free. And I hope you will all stay curious, and I'll see you next time. Bye-bye.